Welcome to another episode of Medicine and the Machine with my wonderful co-host Eric Topol. This is Abraham Verghese, and we're really excited today to revisit with a colleague who we spoke to very early in the outbreak of SARS COVID, an ICU physician talking about the stresses, the challenges of being in the ICU, planning for the surge, and that is my colleague Angela Rogers. Angela is an incredible physician, native of Indiana, trained at Harvard Medical School and stayed on there for her residency and her fellowship. Has a very strong research interest in ARDS and in biomarkers. So you can't imagine a better person to be thinking and talking about SARS. And she's done extraordinary research in this area as a basic science investigator, as well as a beloved clinician and teacher of our residents. So Angela, welcome back. It's so good to see you intact after all these many months. Maybe we can just start by asking you, how's it been? Just reflect back on the experience since March.
I think probably like everyone, every human alive right now, it has been a long haul. I've noticed, Abraham, that now in January, meetings are falling off my calendar because I kind of set them that they should end because I figured we'd be in a better, not worse place. And so while I would say certainly clinically, there are a lot of things that are better about COVID now, I feel much more confident that we're doing good standard of care. And we know certain things help our patients in a way that last March, it didn't feel that way at all. And certainly in retrospect, some of our practices trying the best we could, have changed drastically in the face of new evidence and just experience. So I think clinically, there's a lot that's better, but on the flip side, just the fatigue of it all is very real. I think we all feel that. The politicization that happened with COVID and the feeling of distrust, in addition to just the hardship of having so many patients that are sick and dying and their families not able to be there, that combination was really hard. So I would say some things are better and some things are really hard. And part of it is just, it's been a long haul that we thought we'd be in a better place at, and we're not yet.
But before we go to the sort of the more nitty gritty, and I know Eric has a question for you, I just wanted to stay with that for a moment and ask you about, I just from the outside witnessed what I thought was an extraordinary coming together of many different sorts of people to make up the ICU surge teams, and just a lot of great camaraderie and volunteerism. Can you just speak a little bit about what that was like in the ICU?
Yeah, I think in many ways, for me, one of the best parts of COVID has been when you're actually the ICU doctor and you're there and you're caring for the 12 patients in front of you, and you feel like, I can make a tangible difference for these 12 people. I can't change what's happening nationally. The new drugs are being sort of made EUA, and it's like, should we do that based on that evidence? Like those kind of things you can't change, but just the being a doctor for your one patient is great. We, as you know, in California, our surge happened now, like many months in. Our biggest surge happened late. And yes, one of the most moving things has been the number of people that step up and say, yes, I'm in, I will be there. I will give up whatever easier thing I was supposed to be doing to help get through this time. And that's not just from the physician side, certainly nurses, we have PACU nurses, everyone stepping in to say, yes, how can I serve this community and get through this time is very moving.
I wonder, Angela, first, it's great to be with you and get your views and your experience. If you go back this year and, we've seen many reports that there's been improved survival, improved outcomes. How would you rate the things that contributed to that relative to mechanical ventilation, proning, drugs, all the things in the tool chest?
Yeah, one of the things that we were doing early on was intubating patients early. There was definitely the word from China that sometimes patients would crash really suddenly, and that then, getting the PPE on and getting in there could lead to harm. And so we tried that early on, and we're actually intubating patients when they were on 6 liters of oxygen. And I remember myself as the ICU attending having a conversation with a guy that was kind of on his cell on 8 liters, and he was like, "Really, you need to intubate me now?" And I said, "Yes, we this is what we need to do." And he's like, "Okay," and ended up on the vent. What we definitely know is once you are on the ventilator, whether it's because of thick secretions or de-recruiting or what it is, that it is, people tend to have a long haul. And so I would say the fact that we were doing early intubations, from my knowledge, kind of everyone across the country was doing something similar. No doubt in retrospect, a lot of those patients probably could have been okay without it. That patient ended up taking out his own breathing tube a few weeks later, and he did do well. But still, there's this, we now have many, many, many more patients who can bridge on high flow, but very high levels of oxygen, even inhaled nitric oxide, just to stave off intubation, can kind of be there and kind of okay. Their lung compliance is okay. So they hang on sometimes for weeks in ICU, but never need intubation. Those patients, obviously, if they never needed intubation, tend to do pretty well. So to me, that's a big part of it. Whether steroids helps or not, clearly our practice was completely changed by the recovery trial. There was a lingering concern at the time that trial came out that, our death rates were not 30%. It wasn't as high as the recovery trial. And it was like, are we comparing, are our patients, these patients, is always a problem in critical care, but even more so when we're really clinging to one practice changing paper. So I'm not sure about those other things. I definitely think the delaying intubation, just going back to our more standard care is better. I feel like in general, in every way that we were bending standard care before, once we got back to it, things were better. I think as doctors, as I know, we have a tendency to always want to do something. Like that's our modus operandi, is to like, oh, new thing, great, let me give that to my patient. They're really sick, I should do that new thing. And we underestimate how important really good standard of care is that we do in the ICU. Lung protective ventilation, just the basics, lung protective ventilation, not giving tons of fluid, really meticulous watching for super infections, et cetera. Doing the checkbox is important for a reason. So I think we underestimate that and hear about a new MAB that could be helpful, but probably getting back to our standard of care would be my guess is what's been most important.
Angela, from your perspective, what is different about the ARDS in this entity compared to, say, the run-of-the-mill ARDS that you're so used to seeing?
It's a good question, Abraham. One thing that I would say is that partly the people coming through our ICUs are very different. At academic centers like where I trained in Boston or here, we tend to see a lot of people that are very frail. They actually have, metastatic cancer and are undergoing chemotherapy, and then they get a pneumonia. It's actually very rare if I'm in the ICU for 2 weeks to have an immunocompetent host who only has a little diabetes and hypertension. If they get pneumonia, usually they do fine. They even bacterial pneumonia, right? They'll be on the wards. It's rare to have that person come in sick in our tertiary ICUs. And so I think in truth, the patients are pretty different. They're much healthier. I don't think that's been discussed probably enough in society that, it's, there's all this thing in the news about, oh, you're overcalling the COVID deaths. And it's like, these people that are dying of COVID are rare for us, and it's, so I would say that that's one thing, is it's the patients are different. I'm not sure if I answered your question though. Can you say it again, Abraham?
Yeah, and mechanically in terms of the compliance, the secretions, the complications, is this really, should we have a new name for this other than ARDS? Is this something else that we need
So I kind of feel like maybe part of the reason that so many clinical trials are actually working in this disease is that this is more just ARDS. And it's not that they're dying of other things or that this is their 3rd trip to the ICU this year and their family just had enough. I think maybe now we actually have I don't know if you will, cleaner phenotype of just ARDS. I would say that to a certain extent, yes, a lot of people that are on the vent for a really long time. And, there is a variance in lung compliance, that got a lot of, there was this L phenotype and this, like better lung compliance ARDS. But the truth is, when you look in the ARDS clinical trials literature, it wasn't like everyone had super stiff lungs. And on the flip side, some of these patients really have poor lung compliance too. So I'm not sure that's so different. The long haul thing, we have a lot of patients that look really good, and then you extubate them and they just do terribly. They de-recruit, and they have to be reintubated. There's a fair amount of that. And so there has been this lingering feeling of, is there something different about, is there something different? I'm not sure. There are some things that are clearly different. The number of young people we have with strokes and with PEs is far out of the norm for ARDS. So there's no doubt that parts of this syndrome are just really different. I'm not as confident that the ARDS is, or whether in part that we're doing, we have patients on the vent way, way longer, in part because these were young, healthy people who you're pretty convinced would want to continue our care and want to, try an off-the-shelf extra round of steroids, or maybe consider ECMO and lung transplant. Is that just something we don't offer all the time to many ARDS patients because of just because of who the typical people that get ARDS are? I guess the short answer to your question, Abraham, is
it's actually very helpful.
Really long answers.
No, it's good. It's really good. I want to get into another topic that you are into, which is the biomarkers, and the fact that separating out what would be called dysregulated immune response, cytokine storm, the whole issue about how do you use any markers, and also could you respond about the recent data? It used to be mixed, but now there's data to support IL-6 blockade. So can you help us with the markers and the cytokine storm? It seems chaotic, actually.
I would agree. So I would say, just like we just talked about ventilators and ARDS, honestly, I think that there is emerging and pretty good evidence, really led by Carolyn Calfee's group, if people want to search for it at UCSF, that there are subphenotypes of ARDS that have these high inflammatory markers. And they tend to do, it's about a third of patients in multiple ARDS clinical trials who were recruited over decades and in multiple centers and even cohort studies. It's about a third of ARDS patients have this hyperinflammatory phenotype. And not only do they do way worse, they have a much higher risk of mortality, but interestingly, when you subset those clinical trials to those inflamed people, they have differential benefit. Again, this is retrospective. What hasn't happened is to prospectively identify those patients and then just target those in a prospective way. That's what would really need to happen for ARDS. And so that's clearly the case for about a third of patients. But even, when you look at IL-6, surprise, surprise, is one of the key inflammatory markers that defines that subphenotype. It's high IL-6, high TNF, high IL-8, low bicarb. It's exactly the same markers that you'd see in COVID. And so again, is COVID different? Is it hyperinflammatory, or is it partly that we have immunocompetent hosts that have these phenotypes as well? The IL-6 levels in those past ARDS studies, we had a small paper that we published as well. In regular ARDS, IL-6 is high, and it looks a lot like high levels in COVID. So it's not like cytokine storm has always bothered me a little, because there's CAR T cell therapy with really high levels. And then there's ARDS kind of has at least a subset of patients, even the non-hyperinflammatory ARDS patients have IL-6 levels in the range of our sick COVID patients. And so, I wonder first I would say it's so important for us to get this right. And I really hope that as a critical care community, or even society at large, that now knows a lot more about ARDS and respiratory failure, will invest in studying these questions to get it right for our non-COVID patients as well. There were studies for steroids of ARDS. There have been a number, but they've been pretty small, and sometimes they're late, and they're not phenotyped for inflammatory levels. But I think we have to ask those questions again, right? Seeing that when you have a sort of more homogeneous group of patients with COVID that steroids seem to help. And just anecdotally, when they come off their steroids, sometimes their fevers come back, their CRP is still 15, and it's like, and so now it's like, who can we study that? Like those patients seem like they need steroids longer, but it's hard to study them. So if someone wants to do that with me, I'm eager for that late COVID trial, because that's, we know it takes a long time to get better. Are we doing them a favor by hammering away with more anti-inflammatories?
So these are naive questions that I'm going to ask, but I'm curious, first of all, have you seen a change in the phenotype of what comes to the ICU, given all the stuff we're doing at the front end, almost routinely these days with patients with COVID before you see them? And secondly, I know there's been a lot of push to give steroids much earlier, to continue steroids much later. People are probably doing this without our necessarily knowing it, or off protocol. Give us a sense of what that looks like, all the sort of ancillary stuff that's happening before and after ICU.
Yeah, one thing I would say is that to me, it's an unfortunate thing about the recovery trial was amazing. The fact that they did this pragmatic trial so quickly and involved so many hospitals, there was so much that was good about that trial. It would have been so great to be able to zero in on the oxygen level of the patients, that weren't ventilated. How many were on high flow? How many were on, 1 or 2 liters? Did they benefit? To me, an important aspect of that trial is that the people that were on no oxygen had a trend toward harm if they got Decadron. And so we absolutely see patients that are coming in to our hospital whose PCP gave them Decadron and azithromycin in an outpatient setting. And to me, if you're not on oxygen, for sure you shouldn't get it. Should you get Decadron? Should you get it if you're on 1 or 2 liters? That I guess is a little bit of a line in the sand. What's your trajectory? Here at Stanford, we had come to a consensus among ourselves that we would wait for 4 liters, which meant that a lot of people came in and were actually on the wards for a couple of days on a couple of liters of oxygen and went home and never got Decadron. It's a little hard. Our mortality rates have been exceptionally low, as you know, so it felt like a safe thing to do and maybe not expose them to these anti-inflammatories if they didn't need it. So I would say that's kind of the short answer about the steroid part. For us, you have to be X amount of sick to get to ICU. So that might be a good question for someone who's more of a hospitalist who's seeing the range. For us, we're seeing people that have often been enrolled into clinical trials, but still got worse enough to come. Talking to my collaborators, or colleagues across the United States about what's the threshold to come to ICU. We've had a pretty low threshold at Stanford of 6 liters brings you to the ICU, which in our normal circumstance, it's a much higher threshold of oxygen needs, in part just this recognition that they need to be carefully watched. And if they need high flow, they come. When places are under much more surge, sometimes it takes high flow to get there. So then you have much sicker patients on the wards. But we've been able, even with our recent surge, to keep this low threshold, admitting early, getting close nursing, and if everything goes well in a day or 2, off they go, and that's great. So no, I haven't seen a major change in the phenotype. It remains for us overwhelmingly Hispanic patients here at Stanford, people that are in multifamily homes and multiple family members being sick at the same time. That those things haven't changed, and largely respiratory, and then just some devastating strokes.
I was going to ask you about the early treatment before getting to the hospital. We now have monoclonal antibodies, although the combination of Lilly with the 70% reduction in hospitalization and death, which is pretty striking, probably similar with the Regeneron, although their phase 3 trial isn't done. Even though the EUA for the combination isn't yet out there, hopefully it'll be soon. How are we going to get better organized? Because these antibodies are sitting in shells, and they could actually spare you and your colleagues. It seems dismaying that we don't use these therapies that actually could make a difference. What do you think?
That's a controversial topic. I mean, I will say that when I look at the this is one of the cases where I feel like sometimes the really early EUAs with just a few patients, like the 6% versus 1% getting admitted, but it's this tiny N. Right. And it kind of leads people to say, is that true? Would it have, and I completely understand that the decision makers are having to weigh, it's a pandemic. if it's true, it's huge and we've got to get it to the shelf, versus here's a great study that everyone's behind, like recovery or like, the Moderna trial, right? Like that you just look at that and you're like, there is no doubt in my mind we should be doing this. Let me take on one more thing and build a 10-bed place where people can come and get their MAB. You know what I mean? To me, that's one of the hardships, is that a lot of great ID doctors here who read that paper are like, are we sure this is enough? You know what I mean?
Right.
So,
I mean, I'm actually, there is no paper yet. It's just a press release
Right.
this week from Lilly.
Sure.
So you're right.
Sorry, I guess I meant the prior one. I guess.
Yeah, I know. I think you're right. The data were soft.
Yeah.
And especially, with one antibody, we've learned that the escape is so common. It's got to be a cocktail or combo. But what, I guess, do you have an infusion center in Stanford or Palo Alto? And are you ready for the next phase when hopefully we can keep people from coming into the hospital?
Right. So it's a good question. So I think you're right that to me, when people asked me before, based on the prior data, I think that was a limitation, is that if the people, everyone's kind of working 130% and have been for a year, those same people are going to be the people that need to see that data and say, you know what, it's time. I need to do the things I need to do to get this done. So definitely RED has been working on this. And I know the infectious disease doctors have had a few beds, but my sense is it's like there's a link we can send patients where, send to physicians where they can fill it out and say, I want this person to get it, and they get it. But the N has been small. And I don't think that people were convinced enough by the data to start, really doing a release that says, you have new COVID, come and do these things. But now, as more data emerges that actually is helpful, I think those things, I think a lack of data actually really does influence physician practice in a way that I think is good. And so if there's now better data, that it sounds like it's convinced you, Eric, and that means something given your deep knowledge of the field, then I think those things will start to happen much more. It would make me hope that practice would change.
We want to spare you because people that are in the ICU have really been hit as hard as you can imagine. I mean, yeah. So we're trying to come up with ways that it would be reduced. And I was going to get to later. I'm going to turn back to Abraham about the longer haul going forward.
I was just going to say actually the same thing, and then I'll turn it to Abraham too, which is that if we can avoid an ICU stay, that's awesome. If we can avoid mechanical ventilation, that's awesome. Even, the data about long-term effects of critical illness, even aside from the mechanical ventilation, even aside from COVID, are that just having sepsis sets people back. Like you just having a bad infection that leads to hospitalization has a long tail. Just like ARDS, I'm not as convinced that COVID is so different. We're just focusing on it more because it's a lot of young, healthy people that are complaining of this long haul syndrome. But it's a real tale. And so I agree with you 100%. If people don't need me, I'm thrilled for them.
Actually, my question was about the tail, because I know there are some fairly vocal colleagues of yours who are really keen to keep steroids going in some form on discharge from the ICU, or perhaps even discharge from the hospital. And how do you balance sort of, experienced clinicians' clinical sense that this is what the patient needs versus the data that's not yet there? What are we now doing for those patients?
I can't comment as much on the, steroids at departure thing. That I'm not sure, but I can tell you that as an ICU doctor, I have patients that finish their Decadron and then they look worse. Their fevers come back. You look everywhere for infection. Their CRP's sky high. They're still on the ventilator. And in fact, it's rising. And you're like, it has to be their inflammation, right? And so you're left with, so we actually at Stanford have just developed this is what we do with steroids in late ARDS, which includes giving them, because your alternative, right, is just, so if you're convinced they don't have infection, I would want, I think, to have a try of it. If there was a clinical trial that we could enroll our patients in to definitively answer the question, I would love to enroll my patients, and I would be willing to do it myself. But in the absence of that, when you have sky high inflammation and a patient worsening clinically, it feels like the risk benefit is there for steroids, so we are doing it. But these are patients where your alternative is essentially death and ECMO, then for sure, or waiting a little longer and then doing it later. But we have data now that patients on autopsy often have cryptogenic organizing pneumonia, and that can be steroid responsive, right? And so that for us has partly tilted us toward more steroids. The recovery trial, this data from autopsies, our own experience of just patients, 40-year-olds rejected for ECMO, you try it and they do get better. We all know in medicine that an N of 1 is a hard way to practice, but to my knowledge, this isn't being studied, Abraham, and I think it's an important thing that we should be studying. Just like with convalescent plasma, the fact that 40,000 people got it and there was no placebo arm, so we don't know if it was helpful, just kind of got it under EUA. It's the same with steroids. Everyone I know is doing this sometimes, but the only way to really know is, it strikes me, through clinical trials. I think COVID has taught us that as much as any other disease.
Well, I'm glad you brought up the convalescent plasma, because now we're talking about a therapy that's been used, putative therapy, in hundreds of thousands of Americans, often late, and without assurance that there's high titers of, monoclonal or polyclonal antibodies. So that's, of course, as you pointed out earlier, an EUA was given in August without sufficient data. There still are not sufficient data, but what it has done is help to select out variants. Now, we don't have one potentially in the US, but by throwing all these antibodies to people who survive and are infectious for some period of time, it certainly could contribute. Of course, the worst part is that we've not contained the virus here and many other countries. And also we have immunocompromised people that you touched on who have accelerated evolution of the virus inside them. Now, today and yesterday, we got some very depressing news. And that is that the South African variant is resistant to a fair extent to the vaccines. And probably that also applies to the Brazil variant because it's very similar. And we also saw the B117 UK variant has some, although less, resistance from the Novavax. So what we're looking at here is a much longer pandemic, unfortunately. And so now that we have established this kind of fatigue factor that's, just extraordinary, how do you see us getting through a longer path to an exit strategy or exit time? I mean, instead of maybe 6 months, we're looking at a much longer time, perhaps. What are your thoughts about that?
This is where the transcriptions can say long pause.
Yeah.
I will say, part of, with our rise of cases, like our California wave was happening over the holidays and happening at a time that the hospital didn't want to shut down all elective surgeries because we know that harmed patients too. And so it was kind of this operating at 90%, but can everyone, just squeeze in the COVID, it was really hard. And for our emotional sakes, it was so helpful to feel like, but the vaccines are coming. You know what I mean? Like that made a huge emotional difference for us to think that, okay, this is the last surge, if we can all get through this together, yes, it's going to be a rough winter, but then spring will come and people will be vaccinated and we're going to get our lives back, was really important for us. And it's honestly hard to think about. What do you do if like April is just as bad and worse? And, because it's this, like you said, the same trainees that, want to move on from COVID. I totally get that. I love ARDS. Not everyone does. And it's a harder sell when you're coming back to the ICU for the X time and your long-term goal is outpatient medicine. So I think it's taxing for me. I'm hopeful, sort of reading in the literature that it sounds like in South Africa, the mitigation, if people really wore their masks and stayed socially distanced, that should help too. I am happy that it feels like the tenor of doctors are lying, scientists, this isn't real, that seems to have died down. that maybe if we could get the social aspects of COVID around, that even a less effective vaccine plus, more of a community feel of we're all in this together and we're going to do this, that maybe that could still be enough to have it not be as bad as this fall has been for so many areas of our country. I hope that combo could still work. I've heard 50% efficacy. I know, we were so lucky with the 95, but
Right.
I'll take 50 plus a serious investment in masking and at least not undercutting that it matters.
Yeah, I mean, I was just going to say that, with this UK B117, and it's at least 50%, super spreader potential effect, and it's already here. We're looking at a pretty grim several weeks ahead. And as you say, if we could all band together and do the things we know work, we could forestall this and blunt it. And it's so hard to watch the lack of unity and the lack of a cohesive response. So
yeah.
Anyway,
I have been really encouraged by, sort of the new administration's efforts.
Mm-hmm.
I think they have an amazing team working on it. I think, also, the community is eager for vaccines. There was a question 6 months ago of would people even take it? To me, watching the frenzy around people wanting the vaccine, at least there are a lot of people that will accept the vaccine. Those kind of things are good. I hope, I have a fight with my husband sometimes when we go for walks because he's like, we're 8 feet from people. What's the data that it matters? And I say, but as a community, those people care. They feel cared for by your mask, even if we are outside on a walk. Please just do it as a member of the community, and because partly if you see the mask, then when you do see someone, you don't reflexively go up to them and break the rules. But, I can't even control my own household. So, but I think if as a community, we could all see it as our duty and we could all get to 90%, then even a 50% efficacious vaccine could get us there, plus hopefully summer and getting back outside, maybe I think as a community that has really hampered us here in the United States, that we didn't band together. And I know it's not easy to say that we should, but I think it could be so important.
This question is really for my co-host, Eric, because a couple of days ago, we had the benefit of hearing him at Grand Rounds at Stanford. And you struck a more optimistic note, Eric, and there's been breaking news, as you said, in the last couple of days. Help us sort of understand where we are now in terms of vaccines, present and past and future, and, what exactly are the things we should be looking for going ahead?
Well, thanks, Abraham. I think the concern as Wednesday, we had only in vitro evidence of immune escape for these two variants, South Africa. Well, the Brazil one is really quite similar, its properties for immune escape in the experimental neutralization assays. And then the UK, it looked like it was not going to be a problem. And then within the last 24 hours, we've got these two now large trials showing unequivocal evidence of drop-off, which we hope wasn't the case because we knew that the neutralization antibodies from vaccines are like superhuman, the exponential levels. So we figured, oh, well, these variants, they can't be that bad, right? It turns out they really are. The one today, J&J, it dropped down from, in the 70s to the 50s for South Africa. And then even worse, in Novavax, it dropped down from almost 90% to 49% for South Africa. So we're looking at trouble here. It doesn't mean, I think as Angela's pointed out, we're going to still have efficacy. That's good. But we're also going to see further evolution of this virus if we don't ever get containment. Look where it's happened: South Africa, Brazil, UK, and we're going to be part of that story too. That we're like one of the worst countries in the world. So I think that it's really disillusioning because up until the last day, we actually thought we would get out of this with our great vaccines, and now we know these. South African arrived, I'm sure earlier, but it was documented yesterday for the first time, the 2 community transmission cases in South Carolina. So, I think knowing that all our colleagues are pretty burnt out now to think that we could go longer It's tough. Even though we were privileged to get the first round of our vaccines, it's almost like we're getting loaded up so we can go through a long round of the same, and it's concerning.
Eric, do you have any evidence that these strains are having increased mortality? Do the trials suggest that as well?
Yeah, well, the worrisome thing was that the group in the UK called NerveTag, they looked at all their data for their variant, which is now quite dominant, and consistently through various data sets, they found a 30% increase in lethality. And that's what led to the press conference last week with Boris Johnson saying, folks, we don't only have a super spreader variant, but we also have one that independently of that causes more lethality. So the transmission increase was bad enough because that meant more people in the hospital, more deaths. And what the reason I'm concerned right now is, we've seen ICUs, hospitals past the breaking point. And now we've got a strain that's going to get dominant unless we go, really hyper aggressive right now when the cases are going down, and get them down, as low as we can, and do all the right things that we know, like, even better masks and home rapid antigen tests. But we're just like watching, it's not getting done. I do agree with Angela that we have a great administration, great team. And hell, they only been in the work for 8 days. My goodness, how much can you expect from them? If only they had been there, a year ago, we wouldn't be in this situation.
And also, just thinking, I would say my sense as physicians is that we often, it's like me as an ICU doctor, we care for the 10 patients in front of us, but are not as involved in our societies as we probably should be, in the inequities that we recognize in healthcare. But thinking about how do we get back so that others trust that amazing team too? How do we engage our communities so that people say, well, the data isn't clear, but I trust my physicians who say wear my mask, or to get the vaccine. I think, as a physician community that I know is mainly listening to this podcast, I'd say, what can we all be doing to try to have our communities come together?
Yeah. As we wind down, perhaps you can reflect on, what you, the nurses, all of you who are in the ICU have been doing to sort of stay resilient, to keep the faith. And have you seen sort of any permanent changes in the way we do ICU based on our experiences with the SARS?
I guess, Abraham, I would say on a day-to-day basis of being in the COVID ICU, I tell our trainees and anyone who will listen that I think it's one of the most incredible, privileges in critical care to get to be the doctor for these sick patients that have an amazing prognosis if we can only get them through. And so I would say that actually the day-to-day life of being there is positive. And I think the teamwork, but it's just so recognized that everyone is doing their best and working hard for the patients. I would say the biggest thing that I think has changed, one of the hardest things about the whole period has been the politicization and the fact that, when you'd get home after 16 hours at work, you'd log on to Facebook and share a story and people would say doctors are exaggerating, or that it's not true. That feeling when you're that tired, you just have to step away. But it's hard because I think, just as Eric said, this is the time we have to not step away, that we have to serve our community that's not our 10 patients, but looking outward. I would say that the racial injustice focus of last summer, and coinciding with seeing that nearly every patient I have speaks Spanish in my COVID ICU. In medicine, we have a problem that we have not been outward facing enough. So that is something I think must change and has changed. I think there's no one that works in our COVID ICU that doesn't see that this isn't fair. This isn't how medicine should be. So I think that's a change. Being there in the day and getting to work with others is, I think, what drew a lot of us to ICU in the first place.
One thing I was going to ask you in closing, Angela, you're a great inspiration to us. And I think that there's more people applying to medical school now than ever before. So we have some of these people tuning in, and we have, medical students. What would you say to them, having been through all you have and your colleagues over the last year?
Eric, I'll tell you that we have more people applying into pulmonary critical care this year from our residency than we've ever had before. Obviously it's a self-selected crowd that comes to my fellowship interviews because they didn't hate COVID or they wouldn't be there. But there are a lot of, I think it speaks to our profession that really we want to serve, and that you're serving when you have a person who had mild obesity and hypertension and was so close to dying and they get better. There's, it's amazing to get to be involved in their care. And so when I talk to trainees who are applying, I tell them, there is no better time to become a doctor than now, to get to serve the community. I think this outward facing thing is important. It's so obvious that science matters, right? But we haven't been good enough at you being on Twitter and convincing people. So I think, if we could do that, it's an amazing career. I love to get to be an ICU doctor. And there's nothing about, I think COVID brings up some things that are wrong with our society for sure. But as doctors, we have a voice for our patients and for the community that's so important. So I'm thrilled to hear that there are more people applying than ever. It's an amazing time to become a physician.
Wow. For our listeners, Peabody said many years ago that the secret of the care of the patient is caring for the patient. And I don't think anybody I know embodies that more than Angela. For those of you who don't get to work with her, she's also an associate program director, also an incredible teacher and physician. And I hope, Angela, that you get to influence many more people with the kind of enthusiasm and optimism you have for medicine and really for waving the flag of the faith of what we do and the importance of this profession. So I thank you for taking the time to do this. Eric, any closing words?
No, what a great opportunity to talk to Angela today. And it's always wonderful to have an inspirational force when we need it, and we sure need it right now. So it's great. Thank you, Ann.
Well, thank you so much. I feel the same about both of you, and thanks so much for giving me the honor of getting to speak to your audience again.